Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. These are real conversations with physician experts from around the largest healthcare system in the Maryland, D.C. region. In the early 2000s, policymakers in healthcare began to recognize that patients being readmitted to a hospital within days and weeks of being discharged is a serious public health problem. Hospital readmissions are associated with increased illness, death, and higher healthcare costs. By 2012, policy changes made through the Affordable Care Act, hospitals could be penalized if patients are readmitted within 30 days of going home. Over the past 2 decades, dozens of plans and programs have been implemented across the U.S. to ensure quality care does not end when patients go home. Today on MedStar Health DocTalk, we've invited emergency physician Dr. Ethan Booker, the Chief Medical Officer of Telehealth and a leader of the MedStar Institute for Innovation, to share some innovative ways hospitals are reducing patient readmissions. Maybe one is right for you and your loved one. I'm your host, Deborah Schindler. Dr. Booker, thank you for joining me here on DocTalk.
Thank you, Deborah. Great to be here.
You and I first met during the pandemic when we were doing news stories on telehealth because they were new and in demand. They became a necessity during the pandemic, but really how fortunate were we that the technology was ready?
That's a great question. Great to see you again. Be reminded of those accelerated days.
Yes,
back in the early portion of 2020. So as you pointed out, we were able to sort of quickly pivot and build capabilities for meeting patients' needs in 2020 because we've made an investment going back quite a ways, actually, nearly a decade before that, into understanding what was possible through telehealth. And in 2017, within the MedStar Institute for Innovation, we founded the MedStar Telehealth Innovation Center to really formalize our investigations into telehealth and kind of build the capabilities. So in 2019, we had a small team of people who were building those technologies out, kind of anticipating where healthcare might go. And I think if you'd have asked me in 2019, where we were going to be, I would have told you it was going to be a decade until we used a lot of the tools that we were building. And it was maybe 6 months later that we had to use a lot of those tools. And so I think it's, the corollary I think that you draw here is, MI2, the MedStar Institute for Innovation, really looks to investigate what's likely to be needed, not necessarily tomorrow, but day after tomorrow, to give the health system, both the MedStar Health as a health system, but the health system in general around us as a community, the agility to meet the needs of tomorrow and the day after tomorrow.
So MI2, explain the name MI2 and what it is actually. It sounds like the think tank. Is that safe to call it that, the think tank of MedStar Health?
Well, I think, the MedStar Institute for Innovation, MI2, certainly has some of the features of a think tank. We think of MI2 as the organization that explores, builds, and supports the scale of innovations that help deliver the high quality, safe care that MedStar is committed to. Certainly thinking and innovation happen throughout the organization, and we really feel a role of convening that thought and that energy around innovation, but also really exploring what might be new and next. And I think, as a person who is still practicing emergency medicine, when you're in the front line of care delivery, you're really making sure you're doing the job that's right in front of you. And so having an Institute for Innovation and putting resources there to give people the space to look a little further, to go out and explore, to kind of see what needs to be built is an important part of an investment in creating, again, that agility that a health system needs to pivot to what's next. I think we certainly do think, but we also build. And so it's not just a think tank that's kind of creating positions or documenting what we could do, but it's also creating the vendor relationships, exploring the technology, sometimes writing new software, creating workforce that needs to support these tools. So it's not just about kind of imagining it. It's also going out and prototyping it and building it and working with partners out in the organization to make sure that we don't just do pilots for pilot's sake, that we learn in service of scale.
And I guess on the back end of all that innovation, there's copyrights or licensing and legal stuff. And
sometimes, yeah, certainly sometimes. A portion of our organization, MI2, consists of a kind of collection of things. There's my portion of it, which is the MedStar Telehealth Innovation Center and the Care Innovation Lab. But there are some corollaries to the Care Innovation Lab, including the Business Innovation Lab, which is really about that function that you describe. How do we take the best from the outside and bring it into MedStar? And sometimes that's through partner relationships that allow us to really flex our muscle around know-how while the vendors are coming to us. And then there's certainly the opportunity for the good ideas that start in MedStar Health to go out to market. So we're definitely, MI2 is within MedStar Health. We are very much focused on the problems and opportunities of MedStar Health, but we try to sit very much at the edge of the organization to pay attention to what's going on in technology spaces which may be adjacent to healthcare. Also what other healthcare folks are doing, what's happening in venture markets. Obviously lots of folks are interested in what's happening in AI right now, and MI2 is focused on understanding that through the Information Innovation Lab. And so, definitely that sort of interface between the broader world of innovation and technology and what happens at MedStar Health, a lot of that, not all of it, but a lot of that comes through MI2.
Well, that sounds all-consuming, actually, at MI2 and the work that you're doing there. But you're an emergency room physician, too.
Yes.
At MedStar Washington Hospital Center, which is one of the top 25 largest hospitals in the country. I mean, the ED is emergency department, ER, known by the consumer world, is huge at MedStar Washington Hospital Center. How do you juggle the two? And does your work in the ED, in the ER, lend itself to the work that you do with MI2?
Oh, absolutely. They're synergistic. Right. I mean, the wonderful thing about doing both of those things, right, is that you get to work over a variety of scales, right? So I've been at MedStar Washington Hospital Center in that emergency department for approaching 20 years now. And part of what has led me into a focus around innovation and these opportunities is working in an urban emergency department is a very good window into understanding what opportunities exist in improving healthcare, right? I mean, I think if you talk to anybody about what you'd like a health system to do, many people will describe decreasing emergency department visits, right? And so the reason they describe that is because when other parts of the system are not meeting patients' needs, they end up in emergency departments. And so emergency physicians in urban emergency departments have a really good window into places where the system is not meeting people's needs. You begin to understand, have that sort of system focus.
Such as what? Give me an example of what you're referring to.
Well, so the inability, say, for instance, to get into a specialist to see someone for cardiac disease, and having that disease worsen over time and resulting in an emergency department visit. That's a sort of classic example that many people would say we should keep our heart failure patients out of emergency departments, for instance. There's the sort of pathophysiology of illness, but there's also sort of social condition, right? There's inability to access insurance, access housing, those things that often also do lead to emergency department visits. And then there's just the ability to have continuity of care, where people are getting their needs met. And that bridges across kind of any and everything. That could be oncologic care. It could be, obstetric care. It's very largely about behavioral health, obviously, in emergency departments in urban areas. And so, those things come to my emergency department. And I think getting back to the question you asked about sort of the synergy of those things, certainly understanding operational opportunity and having a system perspective is an important part of what I've learned as a physician in an emergency department. But being able to do the work that I do at the innovation scale and also seeing patients at the individual scale means that I get an N of one experience as a physician, right? I go in and I see one patient, I take care of one patient's needs and the family's needs and try to understand deeply that one patient. At the operational scale through telehealth or other innovations, you're talking about the ability to impact thousands of people. We also do work at MI2 around research or policy, and then you're talking about the scale of hundreds of thousands. And if you're talking at, governmental policy that you might have an impact on, which is some work that we do, you're talking about millions, right? And so the ability to work across that entire spectrum of scale from the N of one direct patient care delivery to thousands through operational improvement to ideally millions through research and advocacy is just thrilling. It's cool to work across all of that.
Okay, so let's go back. You said you started working for solutions about patients being seen via telehealth 2 years before, and just to qualify telehealth. It's like FaceTime for a healthcare visit. Is that fair?
So certainly a live two-way video between a patient and a provider is a pretty stereotypical telehealth encounter. But many of the people in the telehealth industry would describe a broader envelope that would include things like remote patient monitoring. So that's a patient at home with technology that's collecting vital signs and asking questions and creating a data environment that a remote provider can then engage through. So RPM, remote patient monitoring, is usually collected in the envelope of telehealth as a technology tool. And then, there's also, in addition to the sort of workflow of patient to provider like FaceTime, there's also provider to provider, right? So the thing I mentioned before, telestroke, is a circumstance in which, say, an emergency physician at, MedStar St. Mary's, for instance, has a patient who may have stroke, and they're reaching out to one of the vascular neurology specialists at Georgetown to get guidance there. And the patient's involved in that video, but the primary interaction is really between the two clinicians.
Was one of the goals of this formation of telehealth to reduce readmissions?
Readmissions is a very broadly defined quality metric that every health system is held accountable to. And as you pointed out in your introduction, this has increasingly been a focus of, federal payers and Medicare, but also commercial payers to want to decrease hospital readmissions for all of the very good reasons that you pointed out in the beginning. I think as you think about what we've tried to build in telehealth, we're really talking about capability building, meaning what are the tools that people need to deliver the kinds of services that can meet multiple endpoints? Like, how do we just improve the continuity of care, the quality of care, access to care, and that we have an expectation that if we build good capabilities about delivering care, that we'll be able to meet these quality and safety goals that the organization has. But there is not a direct correlation between we will build this capability and it'll achieve exactly this thing. Again, we're an innovation shop, and so we're often focused on building things whose endpoints are a little bit less clear than something like, say, a PI or a process improvement group, which has a very clear quality endpoint. We're really focused on that, again, day after tomorrow, capability building that we have an expectation is going to deliver some value across a really broad spectrum of things. But we're not always perfectly sure which quality metric or which outcome we're going to apply that capability to.
Okay, I'm trying to make the connection then between innovation and reducing readmissions.
Sure. I think the toolkit of innovation as it applies to the question of being readmitted to the hospital is a complex one. I think certainly the idea of readmissions as an endpoint from quality is important to lots of people, like you pointed out in the beginning. But I think the opportunity around innovation, whether that's new ways of working in process, new technology, new payment methods, which can certainly be part of an innovation package, are about really reformatting the care experience from one that's strictly geographic to one that's much more patient journey centered, right? I think one of the realities of I mentioned I've been an ER doctor for 20 years, a little bit more than that now when you add in residency. But I think that there's a conception that the hospital is a place where a previously reasonably well person gets suddenly sick, goes in, gets better, goes home. It's really not the experience of the acute hospital that most health systems actually have, which is the care of patients who have chronic illness, who decompensate, and who need to be sort of put back onto the right path. And I think the model, sort of the conceptual model of a well person who gets sick and needs the hospital for a brief amount of time, it really doesn't serve how patients actually need care pretty continuously. So innovation, particularly the way that I think about it, whether it's telehealth or delivering care in the home, which is one of the things I think we'll talk about, is sort of creating this patient journey from sort of delivering care where you're at, meaning whether that's in your home or in your doctor's office, identifying your needs, keeping you well. And then if in fact you need the hospital, creating a journey through that hospital situation, whether that starts in the emergency department or elsewhere, where we're anticipating your needs as you go back into your regular life. And so that means not necessarily focusing a bunch of technology around preventing readmissions. It's about refocusing the way we care for people through that entire journey, understanding that one of the things we're going to be held to account for is whether or not you successfully stay home after you've left. So I think there's just an opportunity to rethink about what that care journey looks like, to focus it much more on a patient journey and understand that the hospital is a portion of that journey, and that we need to create an environment as you leave the hospital that kind of creates continuity. So most of what we think about as we think about the technology or communications post-hospital is really that 30-day period of time where you're at highest risk for coming back to the hospital, where we need to create an environment of safety around that patient. And that means communications with maybe folks that were in part of that hospital care, communications with whoever's going to be taking on that longitudinal care continuity relationship out for years, ideally. And what are the services that you need kind of right away in that short time frame?
Okay, we're getting ahead because we're talking about home health care, and that's just one initiative that we have come up with, or the healthcare industry has come up with, to try to reduce readmissions. What are some of the other ways, the other approaches to keep patients from coming back within that 30-day period?
Yeah, I think it's a really interesting question, and I think a lot of folks have spent considerable amount of time and effort to kind of understand what are the things that you need to prevent folks from coming back to the hospital. What are things that create that safe environment for discharge? And the answer is that there is no single thing that works. What does work is a multidisciplinary team approach to understanding what an individual patient's needs are and then suiting your solution to those needs. The only thing that's ever been demonstrated to work in the evidence around readmission reduction is that multidisciplinary approach that actually allows you to understand what any particular patient might need. And so as you think about what is the technology approach to that, getting back to the innovation focus that we try to bring to these things, where are the gaps in that toolkit of those multidisciplinary teams? So as a hospitalist and case manager and a transition care nurse and a primary care doctor, look at that patient's needs as they leave the hospital. What is that patient going to need? Are they going to need rehab in their home? Are they going to need home health for wound care? What specialist follow-ups do they need? Are there pharmacy needs that are specific? What social needs and transportation needs? It's really about evaluating that N of one experience, that what's this patient going to need to make their transition effective? And our role as an innovation shop is to understand, does that care team have all the tools that they need in a circumstance in which they're assessing that patient? And so, within the last few years, we've continued to look at what technology things might be necessary to kind of create that continuity. And that includes programs like connected transitional care. So that's nurse practitioners who are seeing patients over telehealth as part of that care journey from in the hospital back to reestablishing their care continuity relationship with their primary care doctor.
How does that keep the patient from coming back to the ED?
Well, if you were to look at one thing that happens fairly commonly, it's medications. So medications would be a common area where creating the opportunity to speak to the patient, understand what their needs are, commonly identify medication issues, meaning the patient didn't understand what the changes in medication after they left the hospital were. The patient was not able to get the medications that were prescribed. They're having a side effect from a new medication that caused them to stop taking that medication. So identifying medication errors is if you were to put some buckets of things that are likely to be impactful, medication issues is a big one. Another bucket would be establishing care continuity, meaning discharge from the hospital, there's an expectation you're going to see your primary care doctor. Maybe you need to see a cardiologist and follow up, but not able to schedule. We're able to schedule, but it's going to be weeks away. Don't know what you need to do there. And so that's another circumstance in which patient challenges might arise. But I think if you were to take medications and follow-up appointments as two kind of big buckets and create the tools to improve that, you'd catch a lot of folks.
Which explains the medication management programs, pharmacist consultation, and medication reconciliation on the list of
Absolutely.
ways to help reduce readmissions. Also on here is transportation assistance.
Oh, yeah. Huge. Thinking, just kind of what it is that patients need after they leave the hospital. So there's sometimes even the transportation of getting home itself, like leaving the hospital and getting home. Sometimes folks have, difficulty just with that portion of the transportation. But imagine a circumstance in which you've discharged someone from the hospital with a complex medical need, and they need to have a follow-up appointment with their primary care doctor. They need to have a follow-up with one or two specialists. They need to get to the pharmacy to pick up new medications. They have some PT appointments. That's 5 different transportation
any
challenges.
One of those, right.
And if any one of those doesn't happen, then the care delivery at the end of it doesn't happen. So
their recovery is impacted, and they wind up coming back to the ER.
Absolutely. Because, one of the realities of transportation challenges is that one of the things that's always a fallback with transportation challenge is a 911 call that results in an ambulance that comes back to the emergency department. Transportation is a huge challenge for people after they get out of the hospital, which is part of the reason why I think telehealth is so interesting as a solution here, is if you can deliver those services where the patient doesn't have to be transported anywhere but can stay in their home, you've solved one of those problems. It's not a solution for everything, which is, again, why we continue to look at what are the gaps that we have in our care delivery. And if transportation is going to be an issue, can we deliver the care via telehealth? And if we can't deliver it via telehealth, how do we get somebody into their house?
Last year, MedStar Health partnered with Dispatch Health, which provides in-home care to patients who had been treated in an emergency department or who had been discharged from a hospital unit. Tell me about that partnership.
Yeah, so I think this is a pretty good example of what I mentioned earlier about doing that gap analysis and trying to understand, what's the ecosystem of tools we currently have? What are patients likely to need now and tomorrow and day after tomorrow? And looking again at that thing we mentioned earlier about opportunities to improve the readmission rates that we have, opportunities to create more effective and safer discharges, whether that's leaving the emergency department or the inpatient setting, and understanding that a team of people were looking at what are the tools that this patient might need, and understanding that we didn't at the time possess the ability to have a provider, meaning physician, nurse practitioner, or PA, in the patient's house relatively shortly after they'd left one of our facilities, with the ability to check labs, do simple procedures, put in IVs, give medications. It's a pretty robust set of abilities to deliver in the home, and we didn't possess it a few years ago. We have a lot of stuff we can do in the home, and we deliver a lot of care services in the home through home health. It's a different thing to deliver home health, which is nursing care, focus on executing a care plan over an extended period of time. And obviously we deliver a fair amount of telehealth, which is obviously remote. You don't have boots on the ground with the ability to do those hands-on tasks that I mentioned before. And so we looked at this sort of ecosystem of things we were able to deliver after the hospital and determined that this was a gap and that we needed to fill this gap with a new capability. And it was not a capability that we possessed. We didn't have a group of people inside of MedStar who were currently doing that work. We didn't understand that business as well as someone who'd already been doing that business in other geographies. And so rather than building this de novo from scratch, we partnered with someone who'd already demonstrated success in many other markets to come to the DC and Baltimore area to help us build that capability.
So let's walk through the process. Mary is an 83-year-old woman who has family nearby but lives alone. She becomes very sick. She's been passing out. A relative calls 911. She winds up in the ED, in the emergency department, and is admitted into the hospital. After 3 days, she's discharged to go home. What's the typical discharge process?
It's a great question. I'm not sure that there is such a thing as typical. A patient like Mary, who you've described, a 3-day hospitalization for someone who's passed out at home is going to include a fair number of tests, specialists, care providers, and then case management, because the patient that you describe in this circumstance is going to be risk stratified into a high risk for readmission category. Based on her complaint and her age, the chances that she comes back again are going to be high. And so anybody who falls into that high risk category is kind of automatically going to get additional services from case management and be flagged for kind of these resources downstream to kind of understand what she's going to need. So she's going to leave the hospital with a plan of care that's going to include what specialists she needs, what changes to medications she's going to have, and exactly like we talked about before, what transportation, communication with family members to make sure that they understand what the care plan is. And now with this acute care at home capability that we just described in partnership with Dispatch Health, either the case manager or the hospitalist who's discharging Mary can place an order for Dispatch Health to schedule an appointment to be in Mary's home, definitely less than 72 hours. It's usually 2 to 3 days after the patient's been discharged home to kind of go into the home and make a reassessment. So in this particular circumstance, 83 who's passed out, the chances are exactly what we mentioned before. Is there a medication issue? And if medications were changed during the hospitalization, looking through everything that's there that she's taking, going to the medicine cabinet and making sure there's no extras that nobody mentioned beforehand, making sure that the new medications that were prescribed are actually there. If they're not there, tracking them down, making sure that follow-up appointment is made. The nice thing about doing home visits too is looking around the house and knowing that one of the issues of home safety is fall risk, understanding what risks might be in the house that could be addressed. I have a terrific example of actually one of our partners in Dispatch Health actually going into the home and reinforcing the bottom of the sofa to allow the patient to more easily stand, which is the kind of thing you just never figure out unless you're in somebody's house.
If she's had the medical consultation, she's had the demonstrations, instructions on care, scheduled appointments are already set up at her discharge. She gets the discharge summary. Her family's been apprised of all of that. Why is she stratified then to be a high-risk return or readmission? What are some of the reasons that Mary might wind up being a readmission if not for Dispatch Health coming in?
I think it's the particulars of a risk stratification are always going to take age into consideration, and the number of comorbidities, the number of medications, and the particular circumstances of the hospitalization, right? So like an otherwise healthy young person with no medical conditions is going to have a very low risk. An older person who's got a number of comorbidities and more medications is going to be at higher risk. But taking the same two people, one of whom has a more serious diagnosis, like say myocardial infarction, versus a less serious diagnosis will also be risk stratified differently. So that's, the tools to risk stratify there are several different ones. Generally speaking, the older patient with multiple medications is at higher risk for readmission. And we focus a lot of our energy there, right? And so across the country, the high readmission risk, depending upon what kind of hospital you're talking about, somewhere between 12 and 20% of the high-risk patients are going to come back to your hospital within 30 days. And so knowing that the readmission risk is that high, that's where you spend your resources.
Does her living alone contribute to that risk?
Certainly. And I think depending upon which readmission risk tool you're using, that may or may not be something that adds into that risk calculation.
In fact, a few days after going home, Mary starts feeling feverish. She's dizzy again. She doesn't have an appointment with her to follow up with her primary care for another week. Through a partnership with Dispatch Health, and she is a real patient, a clinician is already scheduled to go to her home. They send a nurse practitioner who, in Mary's home, took cultures and performed an evaluation, checked her medications, found out that her dizziness was from an inner ear issue, and she was treated right at the house. Dispatch Health's nurse practitioner was able to diagnose Mary with a urinary tract infection and put her on a treatment with proper medications the same day. Is her medical information from that visit now available to you or to MedStar, MedStar Washington Hospital Center, should she ever go back?
It is, yeah. So obviously an important part of this continuity experience is the data that goes along with it, right? I mean, going into someone's home who's just been in the hospital, like by definition, there's going to be complexity there. And so our partnership with Dispatch Health includes the ability for those providers to be able to see our medical records inside of MedStar, to be able to review the hospital course and the discharge summary and look at the medications that were ordered and all of that kind of stuff. They just could not do their work if they didn't have that data. And then on the backside of that, they are a partner that works inside of their own documentation system. So they have their own EHR that they're documenting in and doing that work.
EHR?
Electronic health record. And so when they complete their documentation, that documentation is then integrated back into our medical records. And so that looks like a document just in continuity with everything else. So right into Mary's record is the complete documentation of what happened in the house in the care of Dispatch Health.
The Centers for Disease Control, or the CDC, reported this year that outpatient follow-up care can reduce 30-day readmissions by 21%. And patients who go to their appointments after discharging had better health outcomes. Have you found that the relationship with Dispatch Health and other like initiatives have shown to reduce readmissions or drive other benefits?
Oh, absolutely. I mean, I mentioned earlier in our conversation this program of connected transitional care. So that's a telehealth intervention, right? So it has some similarities. A patient's discharged from the hospital. They have an appointment by video with a nurse practitioner within a few days of being discharged. They cover a lot of the same issues. Medication, transportation, follow-up, any new symptoms or concerns or complaints or things like that. That program's been live in our Southern Maryland and St. Mary's region for quite some time, and it's demonstrated concrete benefit in 30-day readmission reduction.
Excellent.
The Dispatch Health program has been live for a little bit less time. We started in the D.C. area with Washington Hospital Center and MedStar Georgetown University Hospital, and now have expanded into Baltimore and our 4 Baltimore City hospitals. And so the data for that is approaching 600 patient visits now with the program. Looking at that high-risk patient population that we mentioned earlier, we've seen a 7% absolute reduction in 30-day readmissions from patients who have a Dispatch Health provider visit them in the home. 7% absolute reduction in 30-day readmissions in a high-risk group is a really meaningful encounter. So again, it's not a magic thing to do. Delivering care to the patient after they leave the hospital absolutely decreases their risk of being readmitted. I think the importance of what we're building, whether that's a telehealth visit or an in-home visit or a follow-up to your primary care doctor or enrollment in an RPM program.
Program is what?
Remote patient monitoring, that we've got some sort of devices that are collecting vital signs and things like that. I think the important thing is actually understanding what that patient's needs are in their journey and having the toolkit to be able to deliver that care after they leave the hospital. And I think we are certainly focused on those high-risk groups. But my hope through innovation, through technology, is that we get efficient at delivering those kinds of interventions and at understanding what people need, so that it doesn't matter what your risk category is when you're in the hospital, that there's a care plan transition for absolutely everybody who comes through one of our hospitals. Even if your risk of being readmitted is exceptionally low, that you leave the hospital with a very clear idea of what's happening next, what you can do to reach out for help. If the plan doesn't go the way it's supposed to go, who do you reach out to? All of those kinds of things are an important part of making sure that we pivot from an encounter basis, meaning you have a visit here, you have a visit here, you have a hospitalization, there's another visit, to a patient-centered and continuity focus, which is you have a set of medical conditions and you have a team around you who's going to provide care to you across an entire continuum. It's not going to be one person. It really is a team-based approach, and we need technology to be able to connect those teams together effectively. And I think the idea is that how do we, think about technology and innovation and new ways of doing things such that everybody who comes into one of our hospitals has a very clear plan about what's going to happen next with them.
So a patient who is remotely monitored or has a telehealth follow-up visit or is visited by Dispatch Health, let's say they do need to be readmitted.
Sure.
Will that happen?
Yeah, I think that we would all love a circumstance in which hospitalizations were completely effective, meaning you never had to come back. But that's not a reality, right? I mean, some folks are going to have some new problem, right? They're going to have some other complication. 30-day readmissions is probably just a reality. I think, again, putting an ecosystem around a patient who leaves one of our hospitals and creating continuity with them means that we're earlier in detecting those things. And so rather than coming back at 17 days, more decompensated, maybe they come back at 12. And maybe that's the right thing for them to do. And they come back to one of our hospitals, not someplace else, but they come back to us. And they come back with all the context of what's happened out in the world. And so even if they come back in such a way that they need to come through the emergency department and be re-hospitalized, that second hospitalization is ideally more effective than it would have been if we allowed someone to sort of, have those extra 5 days of getting a little bit worse. And then they sort of came back and it wasn't clear what had happened. I think folks are going to come back. And I think making sure that we organize that care journey, again, thinking less about encounter, but care continuum, means that when we receive you back to our emergency department, I know why you're coming back, and I'm prepared to kind of give you the thing that you need for coming back, and that we do that because we've put those things in place after you left the first time.
Have you ever had that happen since you've partnered with Dispatch Health where a patient had to be readmitted?
Sure.
After the visit, after this clinician shows up and says, oh, Mary's doing really poorly? Oh,
absolutely. Yeah,
do they bring them? Does the Dispatch Health clinician drive them in their car?
No. They're not a transportation service.
So they would call 911?
It depends,
maybe.
Right? So I think if they're there with family members who can safely transport them, then they're likely to come back with family. If the patient's sick enough that they require a medical team to do that transport, they're going to call 911. In the circumstances where that has happened, which have not been that many, the Dispatch Health provider stays with the patient until 911 arrives and then does a handoff of care to that 911 team. So yeah, absolutely. I mean, again, I prefaced that this was mostly focused in high-risk patients, and so we've had a good reduction in the number of patients who are coming back to the hospital, but these are still patients with a lot of medical complexity, and the inevitability that they're going to come back to the hospital is there. And it's really about making sure that that return to the hospital is safe and effective, right? That they should come back to ideally the hospital that already knows them, and should come back with the information about why they're coming back, so that we can effectively meet that need.
In this case with Mary, what would be next in terms of Dispatch Health? Do they continue to come back?
Not typically. They certainly can. We've had some in the, again, nearly 600 cases or so that we've had patients seen by that partner. There have been some circumstances where a second visit was required, but it's not a continuity relationship. The dispatch is really about making that transition and ensuring return to the continuity of primary care. So one of the things they do in the house when they're there is kind of review that continuity plan. Who are you going to go see next? Making sure that Mary's going to get back in touch with primary care, making sure that Mary's going to have that follow-up appointment with cardiology that she needs, whatever that is. Another really great circumstance that we had not too long ago of a patient who had been, not unlike Mary, had been discharged after having an event where they had syncope, had passed out. And one of the issues that was going on was an irregular heart rhythm. And so the Dispatch Health provider was in the house, saw that the patient's heart rate was fast, got in touch with the electrophysiologist, the cardiology specialist who deals with rhythm problems of the heart, reviewed the circumstance and made adjustments to medications, and then came back again. I think that was 24 hours or so later to recheck. Heart rate was better, symptoms were better, confirmed the follow-up appointment to the electrophysiologist. That patient's heart rate the first time they came around was 150 beats per minute. 150 beats per minute is almost always a trip back to the emergency department. That's certainly a circumstance in which a return to the hospital was avoided by this intervention. And a big portion of that intervention was about that communication with the specialist who'd been involved in the inpatient care and was going to be part of that continuity experience.
So does anyone who comes to the ED qualify then to be followed up by Dispatch Health or a like program?
No, not everybody.
Just high risk?
Unfortunately. No, it's not actually a risk issue. The program is provided by Dispatch Health, which is a healthcare providing company, and that company has contracts with payers. And so
insurance companies.
Yeah, insurance companies, right? And so obviously the out-of-pocket cost would be significant. And so it's only available to those patients who have it as part of their insurance coverage.
Okay, so Mary
that's not universal.
And Mary won't get a bill.
Well, so Mary, if she's 83, is going to be covered by Medicare. This is an outpatient Medicare service. Outpatient services have a 20% copay as required by Congress. And so I can't waive that.
I see. But what's next on the horizon for reducing readmissions, especially in terms of innovation? What are you working on behind the curtain?
Yeah. Well, I think one of the things that has been true of our innovation shop over the last few years is real focus on effective scale. And so we're still pretty laser focused on making sure that this acute care at home tool is as effective as it can be in the toolkit of those folks who are working very hard to create the ecosystem of care around patients who are leaving the hospital. That's the focus of right now. We are, as I mentioned, we deployed initially in the DC area with our DC-based hospitals. We've relatively recently expanded to Baltimore. There are other hospitals and geographies inside of MedStar that we still need to expand the services to. But I think the broader question of what MedStar Health is doing around readmission reduction, there's a bunch of work going on there. So the clinical care transformation team, who's led by Dr. Ryan Anderson, is focused on readmissions as an area of quality improvement and safety. Part of that effort is not only about globally reducing the 30-day readmission, but also decreasing disparities in outcomes in 30-day readmissions. So we know that there are racial disparities in readmissions, and it's an area of focus for us in a lot of places to make sure that we're not only improving care for everybody, but decreasing the disparities that exist. And so inside of the quality and safety group led by Dr. Jessica Galarraga, there are efforts at disparity reduction in readmissions. There is a relatively new practice council for transitional care that's led by Dr. Luke Carlson. So Dr. Carlson is working on creating the clinical best practices and processes to really systematize and mature our approach on care transitions as an important place where care is being delivered. Care transitions is that entire period of about to leave the hospital, leaving the hospital, and then that approximately 30-day time period where most of the quality-based payments exist, but also where we just know that that's where the risk is. And so I think it's an important part of what we do at MI2 around innovation is to not sort of go off and create shiny objects separate from the important system work that folks are doing there. That's mostly about making sure our workforce is really well supported. We're working with all of those teams to make sure they have the communication tools that they need and continuing to kind of listen carefully to them to try to understand what their evolving technology needs might be, and making sure that anything that we do is really fit within that envelope of system strategic priorities around making care transitions as effective and as safe as they can be.
With the goal of not being readmitted.
Yeah, I think not being readmitted when it's not necessary, right? I think we have to acknowledge that there are circumstances in which the hospital is the right place for care, and making sure that we have, whether that's a phone call or a remote monitoring program or a video visit or, a nurse practitioner in the home or a home health aide or a home health nurse in the home to recognize when someone does need to be returned, if they need to be returned, but also making sure we're providing those services to the patient to make sure that transition is as effective as it can be.
Well, you're clearly very passionate about the work that you do with MI2 and your innovation work.
The thing that I hope innovation brings is not necessarily, a particular technology or particular outcome or endpoint, but really the idea of creating agility. I think our health system needs to be able to respond to what's new, what's next. That's whether there's an infectious pandemic threat like COVID was, or economic concerns or disaster or anything. It's the responsibility of our health system to create the agility to be necessary to deal with what's next. And that requires the forethought of a group like MI2 who's focused on that innovation.
We've been talking with Dr. Ethan Booker at MedStar Health in Columbia, Maryland. Thank you for sharing your expertise with us here on DocTalk.
Oh, thank you, Deborah. It's great fun.
If you live in the Baltimore, D.C. area and would like more information about our acute care at-home services and Dispatch Health partnership, go to medstarhealth.org/services/acute-care-at-home.